Chair will now call Jodi Salvo. Welcome to committee, Ms. Salvo. You may begin when you're ready.
Thank you. Good afternoon. Chairman Wilkin, Vice Chair White, Ranking Member Brown, and members of the Government Oversight Committee. My name is Jodi Salvo. I'm the Director of Substance Use Disorder Prevention at Ohio Guidestone, which was one of the largest nonprofit behavioral health organizations in Ohio. We serve over 34 Ohio counties. I coordinate Empower Tusk, a community substance abuse prevention coalition, and I serve on the advisory council for the Ohio Statewide Prevention Coalition Association, and I'm a board member for the Ohio Prevention Professional Association. I've been in practice for over 20 years in the field of social work and over 10 years in the field of prevention. First, I want to thank you for the opportunity to provide opponent testimony on Senate Bill 261. I do understand the dilemma that the General Assembly is facing on the marijuana issue, but I am opposed to Senate Bill 261 for 4 major reasons. Area of opposition around the extremely high THC products, up to the 90% THC products, advertising, the expansion of medical diagnoses, and removing oversight from the Ohio State Board of Pharmacy and placing under the Department of Commerce. As a prevention professional, our field works to prevent addiction among youth and vulnerable populations. My area of expertise in communities is to reduce risk factors that can lead to substance use addiction and to promote protective factors that help young people lead healthy, drug-free lives. And when we can do that, we can help Ohioans, families, our young people live healthy, thriving lives, and it makes Ohio and our communities healthier and safer. In advocating for healthy communities, I first want us to be very mindful that the pandemic has taken its effect on Ohio. We have experienced catastrophic increases in addiction, overdose deaths, mental health challenges. The last thing we should be exploring right now at this time is how to place more high-potency drugs in our communities. THC products with up to 90% potency have absolutely no place in a medical program, as there are absolutely no studies to be found or research that support the medical benefit of such high potency products. THC products, those high potency, have been shown to be a risk factor in developing cannabis use disorder. In a recent 2022 Harvard study in the Journal of American Medical Association titled Effect of Medical Marijuana Card Ownership on Pain, Insomnia, and Affective Disorder Symptoms in Adults, the findings show that the ownership of a medical marijuana card led to rapid onset and increased incidence and severity of cannabis use disorder in some participants, particularly those with the chief concern of anxiety or depressive symptoms. There were no observed benefits of obtaining a medical marijuana card for pain, anxiety, or depressive symptoms. What is so confusing about marijuana as medicine is a lack of understanding by many about potency, products, research, and the differences between THC and CBD. We absolutely are not denying that medical potential, and we see that often based off our CBD products to address some medical issues. However, when we then look at those high THC products, a lot of those can actually exacerbate the exact thing that we're trying to treat. And I'll say you can see a lot of research on anxiety and depression with that very case. You know, you'll see this medical promise on those lower level CBD products or THC products, but you see that exacerbation that happens with those higher products. So that's where this gets tricky, because it's not just this clear cut, you know, here's a line and this is what happens. So where we're at. The risk of physical dependence, addiction, and other negative consequences such as drug driving increase with exposure to high concentrations of THC. Higher doses of THC are more likely to produce anxiety, agitation, paranoia, psychosis, and suicidality. These harms are costly to individuals and the society by impacting mental health, educational achievement, workplace safety, and raising the risk of addiction and misuse of other substances. These high THC products are of major concern, and these are the products that are more favorable to our young people. We know that the higher THC potency on undeveloped brains, meaning that under the age of 25, is a bad combination for addiction. In our county, we had 2 scenarios of students bringing in edibles to school within the last month and sharing them with their peers. This happened in 2 different school districts among a 6th grade classroom. So a 6th grader brought in edibles, shared them with their classmates, and we had that happen in a freshman classroom, again, within the last month. Our young people are much more likely to initiate marijuana with the high potency products, as these products are much more appealing to our youth and include edibles and vaporization. Please note that our current crisis with young people vaping nicotine has been the on-ramp for young people to use marijuana. Until we get a better control of youth vaping, marijuana products that are vaporized will be particularly appealing to our young people. And again, vaping marijuana is a higher THC product. So Senate Bill 261 will make more access and availability to higher THC marijuana products in our communities, and this has the potential to lead to more marijuana use and addiction. Advertising is another major concern with Senate Bill 261. It allows dispensaries to advertise on social media without receiving approval from the Division of Marijuana Control. We first need to only look at how advertising prescription drugs has served our nation. The United States is one of only 2 countries where drug makers are allowed to market prescriptions directly to the consumers. The United States also takes far more pills than any other country, and we need to ask ourselves, is that a coincidence? If we really want to look at the impact of advertising on addiction for profit industries, we also just need to reflect on what has happened with big tobacco. They marketed that their product was healthy, it was all natural, it had medical benefit, everybody's doing it, you know, that whole bandwagoning approach, and it has hooked generation upon generation, and we fight this, my colleagues that are sitting here, every day. I've been following this issue for years, and please note, advertising creates a decreased perception of harm for our young people. So when you see a decreased perception of harm, because advertising is out there, science shows us there is an increased usage among our young people. So we just need to ask ourselves, is advertising going to go well in Ohio for our medicine? Please I ask you all to reflect. How's big tobacco worked for us? And what role has the pharmaceutical companies had on advertising and the opioid epidemic? It is also concerning that Senate Bill 261 expands marijuana as medicine to treat conditions that are not supported by research. We are opposed to legislatively expanding the types of medical conditions that would comply for treatment without the research to support the expansion. The catch-all provision that would allow a physician to recommend marijuana for any condition is extremely concerning. Please note that the AMA, the Association for Addiction Professionals, the American Psychiatric Association, and I put the Academy of Ophthalmology, and I only threw that one in there because one of our initial conditions was glaucoma, and yet the Glaucoma Association says, yes, we don't support marijuana as medicine. So I really think we need to be looking at what does our major medical associations say about efficacy, what does the research show us. So with that being said, I think we need to look at what are the major medical associations saying, and we acknowledge we've already chosen the path of marijuana as medicine. Let's now ensure that the road we're going down will not lead to a path of destruction by saturating our communities with high potency products under the guise of needed expansion of Ohio's medical marijuana program. This catch-all provision in Senate Bill 261 makes me question if we're really talking about medicine, or is this bill a way to ensure that every Ohio can legally have access to marijuana? Let us look at the proposed expansion diagnosis to include the treatment of opioid use disorder. At this time, there is no evidence that marijuana works to treat the opioid use disorder. And I need you all to know I work very closely with our recovery community. If you are in an abstinence-based program, this is not helpful for you. And, you know, you see people co-using opioids and marijuana. There is not research to support that decrease of opioid use when we're using marijuana. So we can also provide that as well. Initial findings that have been touted by the cannabis industry from the Bachhuber et al. Study, which looked at the time period between 1999 and 2010 of states with medical cannabis laws, said it's demonstrated that these states experience slower increases in opioid overdose mortalities, when in fact another study which used the same methods to extend the Bachhuber et al.'s analysis through 2017 found that the findings from the original analysis did not hold over the longer period of time. But the association between the state medical cannabis laws and opioid overdose mortality reversed directions from negative 21% to a positive 23% and remain positive in accounting for the recreational cannabis laws. I again caution us to reflect on how we move forward as a nation, accepting from pharmaceutical companies that opioid pain medication was the answer to all our problems. As we now know, the industry made billions, and look at the price we paid. Is this any different? Are we going to accept the messaging that the cannabis industry is promoting, that marijuana is a solution to all our medical problems, when in reality they are driven by profits for marijuana use and expansion? We need to learn from the opioid epidemic and protect our people from this addiction for profit industry. My last major area of concern would be removing oversight from the Ohio State Board of Pharmacy and placing it under the Department of Commerce. If indeed we are truly speaking about marijuana as medicine, why would we place the oversight authority of this program under the Department of Commerce? The State Board of Pharmacy has been set up as a single state agency in Ohio responsible for administering and enforcing laws governing the practice of pharmacy and the legal distribution of drugs, whereas the Department of Commerce mission is to promote prosperity for businesses. I know I'm running a little bit long, but in conclusion, please take into consideration these issues and concerns. This particular piece of legislation and any others to expand marijuana access and potency bears much weight and responsibility. The unintended consequences that can come from a marijuana expansion and promotion can cause detrimental negative impact on our people and our state. There are significant negative health and public safety implications to increasing the availability of high-potency drugs to our communities while decreasing the perception of harm around marijuana use. I caution our legislature in moving forward with expansions in the medical program that are not supported by science and research. I think you first must carefully consider Senate Bill 261. Is this really about medicine, or is it one step closer to preparing our state for commercialization? Senate Bill 261 looks to me as if we're playing into the cannabis industry's game plan. We have seen the same course of action in other states. First, we adopt a medical program, then we expand it, and we're getting ready for that end game, which is commercialization. We have a responsibility to our young people, our vulnerable populations, families, communities, and Ohio to do the right thing. My hope is that this committee will see fit to maintain Ohio's current medical program or to take in consideration the concerns provided by opponent testimonies around Senate Bill 261. Thank you for your time and service, and I would welcome any questions.
Thank you very much for your testimony.
Thank you.
Representative Hicks Hudson.
Thank you, Mr. Chair, and thank you so much for coming in and giving your testimony. While it was lengthy, it was also very informative. It raised two questions for me. The first question is, you made reference to a study that looked at the Bachhuber study and came up with a different analysis. Is it possible you could give us the name of that study that did that, so that we can I like to look at that. And then my second question, and you would give that through the chair,
Absolutely.
please.
Thank you.
Then my second question is that there's been a lot of conversation this afternoon talking about the effect of marijuana on young people and their ability to mature, what have you.
Sure.
Could you just delve into that issue a little bit more, if you can, to explain, is there, and also point me in a direction to some information as it relates to impulse control
Absolutely.
for young people.
Absolutely. Thank you. Through the chair to Representative Hudson. I appreciate your question, and I absolutely will provide the research on the buckyballs. So with young people, just to kind of, if I could take a few moments to kind of explain the issue. The THC levels has dramatically increased with marijuana. So 2 to 4% in the 90s. Really, you're looking on the streets right now, 8 to 18% regular marijuana, weed. But our young people, unfortunately, have been introduced to a vaping device in the last couple of years. And when you're vaping marijuana, those percentages are those high THC products. So we have a little bit of a perfect storm happening right now. We have young people that got really comfortable with the nicotine vaping device, and right now it's very easy to get the marijuana piece in there. But basic addiction science lets us know the younger you use a substance, the greater your chance of addiction. So if people are using substances under the age of 21, even though the brain isn't developed to 24, 25, what happens if their brain likes it, their chance of using it increases. So we have the other caveat that our research is not completely here, but we're definitely seeing from research those higher potency products have a greater correlation for addiction. So you have the undeveloped brain, you have the product, you have our young people that just have more access. And you also have this decreased perception of harm happening. And it's not just from Ohio, we're hearing it federally, we're hearing the other states. So as long as our kids, and this is science on all our substances, why we probably have the lowest misuse rate on our young people because prescription drugs is because they hear about it all the time. You know, we see reductions in our other substances because we're providing education all the time. It's really hard to educate our young people when we're having debates all over the nation and we're calling it medicine, and yet they're smart enough to know what 70% THC looks like. And the other thing with our young people, they're not really into smoking. Like smoking a joint that an older person might be more familiar with, that's not going to be their first line of defense. They're going to go right to vaping, or they're going to go to edibles, which are both much higher than smoked weed. So there's a whole bunch of factors playing into place. Thank you.
Follow-up? Representative Seitz.
Thank you, Mr. Chairman. Thank you, Ms. Salvo. I'm intrigued at the comments about THC, and I'm going to read you a couple sentences from a witness who will testify later, I suppose. Okay. A fellow by the name of Pete Nisht from Clutch Cannabis. And here's what he says. Recent studies have shown that a potency increase from 70% to 90% does not have a measurable impact on patient impairment, citing a study from ScienceDaily.com from 2020. Concerns about the potency increase are also mitigated by the fact that these products are sold in metered doses and are subject to the day supply limit for this product type, which is 590 milligrams of THC. So patients won't be able to purchase more THC due to a potency cap increase, but the medicine will cost less due to reduced manufacturing difficulties and will be unaffected by dilutants. But Ohio and Mississippi are the only two of the 38 medical states that have a potency cap. So what would be your reaction to that paragraph that says that the metered dose limit and the fact that we will be eliminating or reducing the need to dilute the product with propylene glycol and other such stuff that people don't really like to take, why isn't that a suitable answer to your arguments about the proposed increase in THC levels in the bill?
Through Chair Wilkin to Representative Seitz. It's very interesting, the study that you're referring to, because I would really challenge whoever provided that to show us any research that shows efficacy for high potency products. So if we're talking 70 to 90%, there is still not research. You can't find it to support high potency THC as medicine. Okay, so I'm going to even go as far to say, once you get over 35%, I don't really care if it's 35, 45, 55. Those are all high THC potency products. They consider mid-range potency 10%. So I don't it's kind of mute how much we're going to mitigate from 70 to 90%. Any way we look at it, those are high potency products which have the potential for addiction. And we saw back in about 2010, that's when we started to see addiction really happen with marijuana. When those potencies were less than 10%, we didn't have cannabis use disorder. When it hit over 10%, that's when we really started to struggle with cannabis use disorder, which is number 2 for treatment in the US after alcohol. So what do we struggle with the most? Alcohol. Number 2 is marijuana in our communities. So that potency, are we really talking medicine when we're at 70, 80, 90%? Research doesn't show that.
Representative Seitz?
Answer, again, you'll hear, if you stay around,
Sure,
which
absolutely.
many of us are probably not going to do, we're not going to spend our life here today, but if you stay around, and maybe you can talk to this fellow if he's here, and he does cite a study that says, as I quoted, the increase from 70 to 90 does not have a measurable effect on patient impairment. So you're saying there's no studies, he's saying there's one study. You know, discuss amongst yourselves, I'm verklempt, as the old line
Through
goes, okay?
Representative Wilkin to Representative Seitz, the caveat is when I'm listening to that, they're saying no impairment, but they're not saying there's medical efficacy in that study.
So you don't care if we go from 70 to 90 then, through the chair?
I'm going to be honest, I think we need to be following the research. What does the science say is an effective THC limit to manage medical issues and concerns? You know, I don't feel like I'm qualified, even though this is a world that I study all the time, to say this is the right THC limit. I think that really needs to come from research and through the medical community if we're talking medicine.
Thanks.
Thank you.
Representative Brown?
Thank you, Chair. Thank you for your testimony. I appreciate it very much. My question focuses on the third of your 4 concerns, the expanding conditions to have more qualifying medical conditions. And specifically, I frankly tend to have some agreement with you with regard to the catch-all provision. I think that's problematic. You also specifically mentioned at this time there's no evidence that marijuana works to treat opioid use disorder, OUD. I am somewhat familiar with research in this area, and I tend to agree with that conclusion as well. My question is, though, with regard to the other newly added maladies, arthritis, migraines, autism spectrum disorder, chronic muscle spasms, and hospice care or terminal illness, are you aware of evidence that medical marijuana works to treat any or all of those conditions?
To Representative Wilkham, to Representative Brown, I appreciate the question. I am also in the same framework that I do not oppose marijuana as medicine. So I will go to, if physicians, if the researchers in those fields, and the AMA says there is medical benefit, I want people to get the help they need. I just feel that catch-all provision gets really scary. And again, I work very closely with that treatment and recovery field. It'll be a nightmare if it's a catch-all that you can have anything, you're in recovery court, and now you're going to say you have medicine
All right.
to get the substance issue you're
Follow-up,
seeking.
Chair.
Follow-up?
Thank you. I appreciate that. So I just want to make sure
Yeah.
that I don't misrepresent your testimony. Your testimony essentially is you don't like the catch-all. That's clear.
Don't like the catch-all.
You don't like the addition of OUD to the list of qualifying medical conditions.
Correct.
With regard to the others I listed, you're not necessarily opposed. You're saying, though, that there should be medical studies that support the efficacy of the use of medical marijuana to treat those conditions and or symptoms of those conditions. So my question was, are you aware of studies that do offer that support at this time? If you're not, that's fine.
I do not at this
Okay.
time on the others. Thank you.
Thank you.
Representative Golonsky?
Thank you to the chair, and thank you for your testimony. I appreciate it. And my question isn't designed to suggest that death or lethality is the only thing we should be looking at, but just so I understand.
Sure.
We've talked about tobacco, we've talked about alcohol, and we've talked about opiate use.
Yes.
And I believe that we all know that use of those substances could translate. Someone could die from those overdoses and so on. I don't know as much as I should know about cannabis use disorder, but from your work in this field, should I be aware that that also could be lethal?
Sure. Through Representative Wilkins to Representative Galunski, thank you for the question. I would say when you look at deaths around marijuana, I would say the one that would probably be the one that would first come to mind if there was a great expansion would be drug driving safety. And I'm sure our State Highway Patrol or any of our officers can kind of let you know the increase that we've had in drug driving. And when you look at states that have commercialized programs, you will definitely see that link. Now, with marijuana, you're probably not going to see, overdoses and that type of death that you would see with the opioid use disorder. But what I would love to have one of our drug court judges here with me, because she does pre-investigative screenings with everyone that comes through her court. And what do you ask? She asks, what was your drug of first use? It's usually marijuana. So when you initiate at those young ages and the potency gets higher and higher and you need more and more drugs to fit your addiction, you can definitely see co-uses with other substances. So a lot of times you're not seeing that real consequence with our young people, even though that we have the research of how does it impact our brain and our IQ and our processing, our learning. But when we get on to, we now have a cannabis use disorder at 14, 15, 16 years old, and you continue to need more drugs because you're chasing that high, that's where we can really see using other substances. That's where we see kind of getting into methamphetamines and cocaine and our heroin, our opioid use. So I feel like it is definitely an on-ramp for our young people to then explore other drugs, which can take them down a path that we probably don't want our young people to go down.
Follow-up?
Yes, thank you to the chair, and again, thank you for that answer. But just because we're broadcasting
Sure.
and so many people can watch what we're
Sure.
doing here today, would your answer be no, that actually cannabis use doesn't actually cause death?
You know what, we have seen overdoses in other states that have commercial industries. We have seen those where extreme psychosis is, people have jumped off buildings, suicide, stuff like that. I would say suicide is probably another link that you would see with cannabis use, at least increase.
If I might, to the chair, but again, and I know I should know more than I do
Yeah.
about this, but just to be clear, where a person could have liver cirrhosis from the use of alcohol, where a person could overdose on opioids and die, and where a person could smoke tobacco for years and then have lung cancer, is it fair to say that actually that there aren't?
I think you hit the nail on the head for what I'm going to say. When you smoke a cigarette, you don't die day one. When you drink alcohol, you do not die day one. It's as you use going down the road. So that cirrhosis of the liver, that dying of emphysema, COPD, or cancer doesn't happen day one. What we also don't know about marijuana is what is the effects of these high potency products. They have not been around that long. So we do not know what the effects are going to be of our young people using high potency marijuana products without the research to say what are those effects going to be.
And thank you for indulging me to the chair, and also you've been very patient with me. But I just didn't want to leave anyone with an impression that if you are you aware of actually any overdose deaths from high potency use of marijuana?
I have to be honest, I have heard those. I would probably have to go get the research, and I can send that to Chair Wilkin if I find that. And I do appreciate those questions, because those are those that we really need to wrestle with. You know, what are the consequences of using substances? And I think in this particular topic, we don't have the long-term research because these high-potency products have not been around but since, 2010, 2012.
Thank you.
Thank you, I appreciate it.
Vice Chair White.
Thank you, Chair. Thank you, Ms. Salvo. The question I had related to your testimony where you talked about the marketing of OxyContin and other opioids.
Yeah.
And the well documentation of Purdue Pharma and how they used advertising to basically launch the opioid epidemic. I'm wondering if you have any research on advertising positive, negative effects with drugs that we could learn from related to how we're going to regulate this advertising or what we're going to permit. If you have anything like that, I'd be interested.
Absolutely. Let me look through some research and I can send it to the Chair Wilkin.
Any other questions for the witness? Seeing none, thank you very much.